Good morning, everyone. Today we're going to talk about a randomized controlled trial of 3 milligrams of latitude in weight of management. First, we have this is a case study. So, the increase in the rate of obesity of a chronic disease with serious health consequences largely explain the recent tripling in the prevalence of diabetes 2. Weight loss of 5 to 10% have been shown to reduce complications related to obesity and improve quality of life. However, weight loss is difficult to maintain with lifestyle intervention alone. About the videos, they are focused on our drug that we talk about. So we have our first video.
My name is Lotte Bjerg Knudsen, and I work for the pharmaceutical company Novo Nordisk, which is located in Copenhagen, Denmark. The purpose of the study that is presented here in this article was to study the mechanism of action for liraglutide in weight loss. Liraglutide is an analog of human GLP-1 that has been engineered to have a long half-life so that it is suitable for once daily injection to patients in a simple pen device. And liraglutide has already been approved for the treatment of type 2 diabetes, but is now in clinical development for the treatment of obesity. We know that liraglutide lowers body weight in humans by increasing feelings of satiety and decreasing feelings of hunger, leading to a lowered energy intake. So the study questions that we asked ourselves here is, does liraglutide enter the brain following peripheral administration, and which GLP-1 receptor expressing regions in the brain are the target for liraglutide, and how are the classical appetite regulating signals affected by liraglutide treatment? When looking at the classical appetite-related signals, we used a rat model where we compared liraglutide not only to a normal control group, but also to a group of animals that had been restricted in their food intake so that they weighed the same as the ones on liraglutide. And what we showed was that liraglutide was able to increase the levels of CARD, did not have any effect on POMC levels, and liraglutide lowered or kept low the levels of HRP and NPY compared to the weight-matched and hungry control animals. When looking at liraglutide access to the brain, we used a novel technique called single-plane illumination microscopy, which can be used to visualize peptide access to whole brain structures. We used a fluorescently labeled version of liraglutide, dosed it to animals, and took out the brain and put them in a scanner, and then started the scanner. So what the scanner does is it collects individual images of sections of the brain, and after the scanning is complete, those can be reconstructed to an entire brain. And what is shown here is a video that can also be found in the supplementing section for the article at the journal website, and if you imagine you sort of peel off the surface of the brain and look into it, you can see that liraglutide is clearly measurable in discrete areas of the brain. When analyzing those structures in more detail, we see that many of those are the circumventricular organs that are known to express GLP-1 receptors, but there are also areas located in the hypothalamus. For example, the arcuate nucleus and the paraventricular nucleus are also directly targeted by liraglutide. When we look specifically at what happened in the arcuate nucleus, we did co-staining with CARD, as shown here. And when we looked at the fluorescent signal from liraglutide, we saw that liraglutide was present in the same neurons that had a strong co-staining for CARD. We also in the article propose a neuronal model for how liraglutide works in the arcuate. It is shown here, and what we propose is that liraglutide directly targets POMC neurons, which are known to have a GLP-1 receptor. But since we know that liraglutide also has important effects to inhibit NPY-AGRP neurons, but those do not have a GLP-1 receptor, then we have proposed a model where this is mediated by a GABA interneuron and that may also have a GLP-1 receptor, or it is effectuated via the POMC neurons. So in summary, when liraglutide is injected peripherally, we clearly detect it not only in the circumventricular organs, but also in discrete sites in the hypothalamus. And we see that liraglutide directly targets the GLP-1 receptor on POMC neurons. And those neurons also respond electrophysiologically to locally applied GLP-1. So the mode of action for liraglutide in body weight regulation seems consistent with a direct activation of POMC card neurons in the arc, mediating an increase in satiety, and an indirect GABA interneuron-dependent inhibition of NPY-AGRP neurons, resulting in a decrease in hunger. And both the increase in satiety and the decrease in hunger have been confirmed in a clinical study. Thank you for watching this little video describing how liraglutide works in regulation of body weight, and I hope that you will enjoy reading the article.
Now we're going to talk about the patients. The trial enrolled patients 18 years old of age or older who had stable body weight and a body mass index of 30 or higher, or 27 or higher if the patient had treated or untreated dyslipidemia or hypertension. All the patients provide writing informated consent before participation. Key exclusion criteria were type 1 or 2 diabetes. The use of medications that cause clinically significant weight gain or loss, previous bariatric surgery, a history of pancreatitis, a history of major depressive or severe psychiatric disorder, and a family or personal history of multiple endocrine neoplasm type 2 or familial medullary thyroid carcinoma. Now we're going to see another video. Now we are going to talk about the study of the case. Remember the drug that is liraglutide? Now we have that randomizing was performed with the use of telephone or web-based system provided by the sponsor. Eligible patients randomly assigned in a 2 by 1 radio to receive once daily cutaneous injection of liraglutide, our drug, starting as a dose of 0.6 mg with weekly 0.6 mg increments to 3 mg or placebo. Both groups receive counseling on lifestyle modifications. We have another video.
Liraglutide. A particular polypeptide analog used in the treatment of diabetes. Liraglutide.
Now we are continuing with the study, the statistical part. We have that patients were evaluated every 2 weeks until week 8. Thereafter, patients were evaluated every 4 weeks until week 44, and were evaluated again at week 50, 56, 58, 60, 64, and 68, and 70. All patients receive standardized counseling of lifestyle modification, approximately monthly. Patients with re-early were asked to return on week 56 for measuring of their weight and recording of adverse events. Now we have another video. This is a video about a woman that received liraglutide, the results.
Hi, it's Tina again, and I thought I would give you an update on my Saxenda journey, or my weight loss journey really. So basically, I have finished exactly 2 weeks of medication. So I'm just starting week 3. So let me update you on my reactions and such. So, the first week was 0.6, and then the second week you increase it to 1.2 milligrams. Now, I wasn't really sure what would happen because I've heard different people say that they had a reaction when they went up. But I have to say, nothing. I could not even tell that I went up, except for my appetite decreased even a little bit more, which is good, if you're trying to lose weight, that is. So that happened. And then today I increased to 1.8, I believe it is. We'll see how that goes, obviously. So let me back up a little bit. I told you about how the first week I had a couple days of sort of a tiny bit of nausea that disappeared. So really, it only seemed like my body took a couple days to adjust to the medication in general, and it's been fine ever since. I have no bathroom issues. I have no tummy troubles, that kind of thing. I will say that this goes along with what I've read on the internet as well. I do better when I eat smaller meals. That's pretty easy because you're not really hungry. But I will say one day, which was yesterday or the day before, I went all day without eating hardly anything. And then I was really, I was actually hungry. I felt weak. So I needed some food, and I ate kind of a bunch of, or a larger meal. And I definitely felt a twinge of nausea. So I was like, okay, so don't eat too much is kind of the lesson in that. Also, I notice when I eat a lot or in one sitting, sometimes I'll have a bunch of burps, and I've also read about that, just kind of some gases and stuff. The great thing I found about this so far is that I don't really eat much at night, which is great, right? Because that's when you can't really burn it off as easily. So I tend to sort of stop eating around 5, I think, and I have a little light early dinner. I'll even have a glass of wine and I've had no issues at all. So if you are having issues at night, like heartburn or burps or whatever, um,
Continuing with exposition, we have that we estimate that with a sample size of 200 for 2,400 patients assigned to receive liraglutide and 1,200 assigned to receive placebo, the study would have more than 99% power to detect a between group difference in the three primary efficacy endpoints of the main 56 weeks trial and the primary endpoint of the 2 years extension. The power for the first complementary endpoint weight change was calculated with the use of two-sided Stoness test at 5% significance level. The power for the two categorical complementary endpoints was calculated with the use of two-sided chi-square test or chi-square test, also at a 5% significant level. Now we are going to see another video.
Hello, my name is John Buse. I'm from the University of North Carolina, and I've been asked by IDOC to address the issue of the recent FDA hearing on the safety and efficacy of liraglutide, a once-a-day